Okay, let's talk about the next entry. Got an entry about a meeting you went to. It says a teaching session about collapsing children.
Okay, yeah.
Can you tell me a little bit more about that?
Yeah, sure. It was a presentation by a consultant paediatric cardiologist regarding when GPs should refer children that have had some kind of collapse or funny turn, I suppose. It was part of the normal protected learning time, which I don't get the opportunity to go to very often because I'm part-time in practice and part-time elsewhere. But I particularly wanted to go to this session because the speaker was normally very good.
Okay. Is that, have you tried to change the days that you work to try and attend more?
It's not possible. So I can pick and choose if I get enough notice. I can pick and choose sessions.
And you've put some reflections here that you're quite happy now of what to do, so you can differentiate between a simple faint and something more sinister when to refer. Could you just maybe expand a little bit on that and sort of practice exactly, how would you do that?
Yeah, I think my main reflections were that it's an uncommon presentation in general practice, and really listening to the speaker, I don't think I learned anything that I didn't already know, in that if a child faints off, has a collapse in assembly when they've been stood up, or on a hot day, or when they're late having their dinner, then and it fits the typical picture for a faint, then obviously I wouldn't think to refer that child. But if a child, say, had a collapse on exercise, or when seated, or there was any suspicion of a neurological event, then that would be a child that I would refer. And although the speaker was very eloquent and presented the information in an engaging fashion and in a very simple fashion, I'm not sure that it was anything I didn't know, but because it's such a rare presentation, I thought I might learn something that I don't think I did.
I think, and sometimes you find that you haven't learned anything new, but in fact you sort of outlined a few things. It's probably made it a bit clearer in your mind about the faint and the exercise, especially with the cardiologist. I think that's quite important, isn't it? They get a bit twitchy about children sort of having funny turns with exercise. Did he talk anything more about that particularly, that episode?
No, it was if any it was as simple as if any child has any sort of funny turn on exertion, then they should see a cardiologist. So it was fairly basic.
Okay, and then from that, you went to the meeting and you got some sort of ideas about how to refer appropriately. Do you think that you need to do anything more with that? Is there any more reading or learning? Has it identified any gaps that you may want to pursue?
I'm not sure. I think it's such an unusual presentation, but then it's such an important area to get right as well, that I wouldn't mind knowing a little bit more about, I suppose, the cardiological problems that can cause collapse. But I guess until I see a child where I suspect that, because most children that you refer to cardiology, you've got a murmur and it's not an innocent sounding murmur. So I guess until I see a patient to hang that sort of clinical picture, it's difficult to assess. Do you know of any guidance or anything?
Usually, when I go to a meeting like that, I've learned a little bit, but maybe not a lot. But it's been something that identifies things that I don't quite know if I know everything. I tend to sort of try to go look away and sort of research things. I mean, I know off the top of my head that there was some nice guidance.
Right. Okay.
In about 2010, it was on funny turns in adults and children.
Right.
So
okay.
I think it was transit loss of consciousness.
Right.
So that'd be quite a good start.
Yeah. Okay.
But I find, how do you find? Do you tend to use nice guidance? Or?
Yeah, I find them helpful. Yeah, the updates that we get, the GP updates are useful, and if it's something that's relevant to practice, I'll read it. Yeah.
And sometimes actually it's quite nice to expand the entry a little bit.
Yes.
Because you probably could have. You wrote a few sentences on reflection, but actually. From what we've talked about, you could have actually put a little bit more in there.
Yes,
And sometimes it's quite nice to sort of move the event on. So you went to a meeting, you learnt a little bit, and then you read the nice guidance and you learnt a little bit more, and made some changes in your practice from that.
Okay.
So maybe we'll put that up, might put that down as an action point for you to sort of expand on the nice guidance and see if there's a...
Okay, thank you, yeah.
All right?
Yeah, thank you.
Okay. you've talked about a significant event here.
Okay,
talk me through that.
This is the guy with renal colic, is it?
Yes, where the wrong drug was prescribed.
Yeah, essentially it was, I was on call and I went to see this chap who had renal colic. He'd had several episodes in the past. He was clinically stable and didn't need admission, but he was in quite severe pain. So I felt it would be appropriate to give him some injected morphine. And I usually carry cyclomorph. So I planned to give him an injection of cyclomorph and asked him to his wife to phone back in about an hour to see how he was getting on, to see if the pain relief had been adequate. I administered the injection and I thought nothing more of it, and they phoned back in about an hour and explained that his pain was no better at all, which I was surprised about because I expect some improvement at least. And when I said, I'll pop back up and see you again, I looked in my drug box and there was the cyclomorph was still there, and I'd actually administered cyclizine.
Okay, I can see from that. But looking through your reflections, you've actually done some good stuff with this, haven't you?
Yeah.
You've turned an event which actually could have had some unfavourable consequences into something quite positive there, really. Can you talk me through what you've done to try and prevent this happening again? Yeah,
sure. Well, I'm not sure this is always the best way to deal with this sort of problem, but firstly I thought if I've got two that start with cyc, then I should probably dump one of them. So I've got rid of cyclizine and just in short I've got prochlorperazine and metoclopramide. So I've got two decent antiemetics, and then I've only stuck with cyclomorph as the one beginning with cyc. Obviously being aware that when patients are in pain at home, you're often not in ideal surroundings to administer medication. The room was quite dark, and we had this the light on, the curtains were shut, and I didn't open the curtains to get some natural daylight in, which in hindsight, you need, if you're administering opiates, I think you should be in a well-lit room and double check the medication yourself. And I also changed the way my drug bag was arranged so that they're all in alphabetical order now. It wouldn't have necessarily prevented the cyclizine cyclomorph because they were too close anyway, but at least I sort of know where roughly to look in my box for them. And then the last thing I did was discussed it at a meeting in case any of my partners were at risk of having a similar event.
I think that's really important, isn't it? The whole purpose of the significant event analysis is to sort of feed back information to try and prevent it. How did they take that? Did they?
I think a couple of them decided to get rid of cyclizine as well.
Okay. And I think the way you've documented that is really, really very, very good. It covers all what we need for revalidation, and I'll be able to sign that significant event off as one of your revalidation significant events. I wanted to talk about one more thing. I wanted to talk about you put a peer questionnaire in. Was there anything else you wanted to talk about before I went on to that?
No, I think we've discussed everything I wanted to discuss.
You've uploaded the peer questionnaire that you've got some brief comments there about sort of some time issues. Can you talk to me about that?
I'm a salaried doctor at the practice, and most of my feedback was very good, and it was certainly my colleagues seem to think I'm clinically sound and safe, but there were a couple of comments about me working more as a locum than a salaried, which I was a bit disappointed with, but I think that's around. I've got children, I have to collect them by 6:30 from the childminder, so I have to get away, and I can't I can't hang around to do any of the extras.
Because there was something about signing scripts that they particularly mentioned that you sort of leave that to the other doctors.
The scripts are signed at the end of the day, and my consultations tend to run a little bit over, so I probably finish about 20 minutes later than maybe the other doctors do, and then that doesn't give me the time to go out and sign the scripts before going. And it is only a small job signing the scripts, but I appreciate that it's something that people get a bit irritated with if somebody isn't doing it. But I don't see what I can do to...
Sometimes it's difficult to juggle things around with timekeeping, etc. Have you thought, obviously you've done the questionnaire and these comments have come back.
Yeah.
Have you thought of any ways you could change maybe your practice, or starting earlier, or?
Yeah, the thing I did think about was, which I don't think I've wrote down actually, is maybe thinking about starting afternoon surgery about 20 minutes or 30 minutes earlier, because that would sort of prevent that shortfall of time that I'm finishing before other people. And that could, of course that takes 20 minutes out from earlier in the day, but I guess that might make me finish a bit earlier to be able to do something.
Maybe they could just give you the scripts a little bit earlier rather than at the end, because it doesn't take long, you can just sign in between some patients, or if you did have a gap between patients.
Yeah, well maybe we should split them, and then I have my pile of scripts, and then that.
Then you know what you're doing.
Yeah, that would be a good idea. Yeah.
How did you find the overall process of doing the questionnaire?
It's a little bit intimidating, I think, to start, but generally the comments were supportive, and it is difficult. I think when you've got other commitments, it's difficult to be as fully engaged as everyone else in the practice, but you know, it'll only be for a limited time, and then I'll be able to work late like everyone else. So yeah, but intimidating start, yeah.
Okay.